All right, so getting into the medications today, drug at number 51, the brand name is Lunesta. Generic name is Eszopiclone. Its mechanism of action is it binds to and potentiates the effect of GABA receptors, leading to a sedative type effect. So, as you can imagine, this medication is classified as a sleeper or a sedative type agent. Again, falls under the classification of a Z drug because the generic name has a Z in it and it's for sleep. So that's a good kind of classification to remember if you're being tested on that. And mechanistically, it works very similar to benzodiazepines. So as you could expect, we are going to have a very, very similar adverse effect profile. So dizziness, confusion, obviously sedation, that's generally what we're trying to do there. Increased risk for falls, particularly in the elderly. Also, associated with most of the sleeping medications, we can have some rare sleep type side effects. And the Z drugs are specifically notorious for this. Sleepwalking, sleep eating, kind of these unique and abnormal sleeping type behaviors. In addition to that, vivid or bad dreams are possible. This is definitely something I've heard patients report. There is a risk of addiction and dependence with these agents, so they are a controlled substance and they are scheduled for there. So with Lunesta specifically, I keep an eye out for patients who are using this long term. Obviously like to try to get them off of a controlled substance long term if at all possible. Do your best to limit dose, so minimize that risk for falls and confusion and other kind of collateral damage. And then, of course, making sure that we're tapering periodically or attempting to taper off periodically. Use it only short term if at all possible is what's recommended because of all the potential negative adverse effects. Be really careful with driving, obviously, operating heavy machinery. That's a great patient education point that needs to be made. And as far as drug interactions go, there's not a ton of them, but I will say the most common ones are probably the kind of overlapping sedative or CNS depressant type interactions. I've seen patients on multiple sleepers, whether it be trazodone or diphenhydramine at night. So pay attention to that we don't overly sedate patients and they're feeling terrible going into the next day. But there's also plenty of other medications and or dietary issues that may contribute to sedation. So, of course, alcohol I think of as a potential beverage that patients might use that's going to potentially worsen the confusion, worsen the sedation, and not make patients feel very great the next day as well or into the next day. And then, of course, we've got prescription type medications such as opioids, for example, that have sedative properties too. So again, lots of meds within that CNS depressant type activity that can cause some interactions there. All right, moving on. Number 52 is Celecoxib. Brand name is Celebrex. Mechanism of action, classification. It is a COX-2 inhibitor. So selective inhibition of COX-2 leads to a reduction of inflammation by reducing prostaglandin production. Now, Celecoxib generally tends to avoid COX-1 inhibition. So probably the biggest benefit of this is there may be less potential for GI bleed. So patients at very high risk for GI bleed, Celecoxib might be a slightly safer alternative. Again, a lot of this is dose dependent, so the higher the dose, the more risky it is. But it may be slightly safer compared to a traditional NSAIDs, such as ibuprofen or diclofenac or any of those medications. Still, there is risk associated with Celecoxib. Be particularly careful in patients on antiplatelets, anticoagulants. That can be an issue. Patients undergoing surgery or planned to be undergoing a surgery, pay attention to that. That's going to increase potentially that bleeding risk slightly. Cardiovascular risks may be greater for Celecoxib than some of the other more traditional NSAIDs. Naproxen has historically been felt to be one of the safer ones, but that's a non-selective NSAID. Celecoxib may be a little bit higher as far as its cardiovascular risk. It can contribute to edema, can potentially worsen CHF, so that's something to pay attention to if we have patients that were increasing furosemide doses, for example, or starting furosemide. Make sure they're not on a medication like a COX-2 inhibitor with Celecoxib here. There are some negative impacts on renal function, so we got to be careful there. In combination with diuretics and ACEs and ARBs, that can increase the risk for acute renal failure. Associated with some of those adverse effects, obviously we can monitor renal function. Also, we may look at CBC, anemia, hemoglobin, bleed risk as well for potential monitoring issues there. All right, moving on to the next medication. We are looking at number 53, and that is systemic estrogen. And I'm going to focus on the formulation of Premarin, which is basically hormone replacement therapy, often abbreviated as HRT. This medication is very effective at reducing menopause-type symptoms such as hot flashes. So that is a good thing, but it certainly comes with plenty of risk as well. So there's an increased risk for blood clots, DVTs, PEs, certain types of cancer like breast cancer, heart disease, stroke has also trended to potentially be at higher risk there as well for patients on hormone replacement therapy. So there's a few things that are probably kind of common sense, but I just want to make sure we say them here. So when educating patients, when discussing hormone replacement therapy with patients, we do want to try to have an exit strategy to make sure that we try to minimize some of those significant risks that I alluded to. So minimize length of therapy, if at all possible, and use the lowest effective dose. So two really common sense things there to try to protect our patients from some of those longer term, higher dose risks of estrogen, systemic estrogen therapy. For patients with an intact uterus, remember to utilize progestin if estrogen is going to be used, and this is ultimately to reduce the risk of uterine cancer. I will touch on here briefly, there is topical estrogen. So this is beneficial, most beneficial for vaginal dryness. And if that's the primary symptom that a patient has, we're likely going to try to just use that because we have less systemic exposure and less risk for DVT-PE and breast cancer and some of those negative things there. So again, try to use topical if we can, if their symptoms are typically locally related, vaginal dryness, for example, there. But with systemic symptoms such as hot flashes, things like that, typically the topical estrogen isn't going to be effective for that. All right, moving on, we got drug number 54, and that is Moxifloxacin. This is considered a quinolone antibiotic. Brand name is Avelox. And its primary use or its classification has historically been a respiratory fluoroquinolone. Not that it can't be used for anything else, because there are some rare situations where it might be, but it's received that designation along with levofloxacin because it has better coverage against some of the main bugs that cause bacterial respiratory infections compared to ciprofloxacin, which is also a quinolone antibiotic. Quinolones like Moxifloxacin inhibit DNA gyrase. That's a good one to remember for any board exams and things of that nature. Those of you taking the NAPLEX, be sure to check out our study materials at meded101.com. But inhibiting DNA gyrase prevents the uncoiling of DNA, which is necessary for bacterial replication. All right, side effect profile. We've got boxed warnings with the quinolones, with moxifloxacin, tendon rupture, CNS adverse effects, neuropathy. Also, there is QTc prolongation risk as well. There are some topical type preparations of moxifloxacin. These typically aren't going to cause those issues compared to systemic administration with oral moxifloxacin, for example. So something to just kind of note there. Quinolones, moxifloxacin, generally considered a bigger, broader gun antibiotic, generally reserved for more resistant bugs and patients at higher risk for hospitalization and or complications from an infection. And again, there are those FDA warnings on some of those risks, but there's also an FDA warning on avoiding use for less serious infections, such as sinusitis, for example. Other things to think about, probably one of the biggest things I think about are binding drug interactions. So if you co-administer moxifloxacin, oral moxifloxacin, with calcium, iron, magnesium, zinc, that's going to bind up the drug, and you're going to potentially get into a situation where you don't have adequate concentrations to help fight the bacterial infection. So that's really probably the biggest drug interaction I think of and am concerned about. QTc prolongation is another one to consider as well. If your patient's on, antipsychotics, antiarrhythmics, other medications that can increase that risk, that's one other drug interaction I did want to touch on. All right, moving on to our last drug, number 55. This is Donepezil. Brand name is Aricept. This is classified as an acetylcholinesterase inhibitor used for various types of dementia. By inhibiting acetylcholinesterase, we ultimately get an increase in acetylcholine. And that's theorized to be an important chemomediator and plays a significant role in memory and brain function. So again, mechanistically, this ultimately leads to an increase in cholinergic function in the central nervous system. Uses, again, alluded to dementia, getting a little bit more specifically, used and indicated in mild to moderate Alzheimer's dementia. It's probably where I see it used most often. Maybe an option in dementia with Lewy bodies as well. I do see it occasionally off-label for other dementias too. I won't go into great detail there, but just know that you may see it. Adverse effect profile, what should you be looking out for? GI. GI side effects is what you should be looking for. Diarrhea, nausea, and vomiting. And coupled with that, we can also cause some weight loss. I can tell you in the world of geriatrics, sometimes that's difficult to figure out. Is it, Donepezil causing the patient to not eat, lose weight, and cause those adverse effects? Or is it their signs and symptoms of dementia and the progression of their disease? So sometimes that can be a challenging thing to kind of figure out. But I think if you think of anticholinergic effects, hopefully you've got those well memorized. Constipation, dry eyes, dry mouth, increasing cholinergic activity, which Donepezil does, will cause the opposite. So that can cause, again, diarrhea, for example. So important to remember kind of that yin and yang, and if you can kind of remember anticholinergic adverse effects, then the opposite will be true when we're using a cholinergic kind of stimulating type medication like Donepezil. One adverse effect that I did want to mention was insomnia, in addition to some of the cholinergic adverse effects. It is typically dosed at night to kind of minimize the risk for having those GI symptoms, or at least noticing some of those GI adverse effects. But rarely I have seen it contribute to insomnia. So in that case, patients tolerating it okay, no issues, but it seems to be keeping them up at night. You could certainly try to switch that dosing to the morning if need be there. There is a weekly patch formulation of Donepezil that's brand new, or within the last couple of years here. That is very expensive. I honestly have not seen it used yet. But again, patients with difficulty swallowing, for example, may be a potential option there. From a drug interaction standpoint, acetylcholinesterase inhibitors can cause some bradycardia, so I do pay attention to that, particularly if you've got a patient on, an antiarrhythmic, a beta blocker, medications like that can affect the heart rate. Acetylcholinesterase inhibitor could drop that heart rate further, so definitely a good one to pay attention to there. And then kind of that interplay with anticholinergics. Using an anticholinergic medication like diphenhydramine, for example, that's going to blunt the effects of Donepezil and potentially block any potential benefit from that medication. So that's an important thing to remember, important thing to educate your patients about when they're looking at potentially taking over-the-counter medications. So really important patient education point there. All right, well, I think that's going to wrap up the podcast for today. Go to reallifepharmacology.com, get your free 31-page PDF on the top 200 drugs. Support the sponsor, med101.com/store. I've got tons of resources there, books, educational materials for all sorts of different healthcare professionals. So go check that out, support the sponsor. Definitely a no-brainer there. If you want to reach out to me, mededucation101@gmail.com. Also, do us a favor, leave us a rating review on whatever platform you're listening on, whether it be iTunes, Spotify, or anywhere else. So I greatly appreciate that. With that said, I'm going to sign off for today. Thank you so much for listening, and I hope you have a great rest of your day.